Hi, Mike Gibson, Richard Cheng from the University of Washington. We're here live from ACC 2025, and we're talking about variant ATTR and wild type ATTR. What are the differences, Richard, and how do we diagnose them? Is there any differences in the diagnostic methods and treatments?
Yeah, no, thank you, Dr. Gibson. I think this is a very important topic because the thing is, in the field, when we think of TTR cardiomyopathy, most individuals think of wild type TTR. These tend to be our elderly gentlemen, 70, 80 years old, they present with wild type TTR. And those patients will often have the classic red flags, which includes, for example, carpal tunnel syndrome, spinal stenosis, and they'll present with cardiomyopathy, typically restrictive. They may have some degree of LV dysfunction, but it's not present in all the individuals.
And what proportion of all of ATTR is wild type?
It's the vast majority.
Vast majority.
But I think as someone that does work in the field, it's really critical that we recognize the individuals with variant TTR also. And I think the clinical presentation is highly variable depending on the genotype. For example, in the United States, the most common genotype is going to be the V122I. This is based on the old nomenclature. But essentially 3 to 4% of African Americans in the United States will carry the gene. Keep in mind that the penetrance is nowhere near 100%. If you look at the SCAN-MP study, which is an ongoing study from Matt Maurer at Columbia University and Rick Ruberg at Boston University, it looks like the penetrance is somewhere between 35 to 50% for V122I. But those individuals tend to present at an older age with predominant cardiomyopathy. On the other hand, in Europeans, for example, commonly we see V30M as well as T60A. And with those variants, they will sometimes present only with polyneuropathy and sometimes with a mixed phenotype. So there are very drastic differences in terms of presentation for TTR cardiomyopathy in terms of whether they have neuropathy or not.
Interesting. And what about disease progression by these different subtypes?
Yeah, so I think that's a good question, right? Based on the older literature, which followed these individuals before the advent of modern day targeted therapies, what we would see is individuals with variant TTR, typically with V122I, their phenotype is much more aggressive. They tend to present, interestingly on imaging, their metrics are not as profound as individuals with wild type just because their disease is much more aggressive. So when they develop disease, they get sicker much faster and they tend to progress faster than the wild type TTRs. So because of that, I think that population tends to be very vulnerable. The other piece to this is sometimes individuals with predominantly neuropathy with maybe a mixed phenotype, sometimes their cardiac disease gets overlooked because individuals focus so much on the neuropathic symptoms that they don't recognize their cardiac phenotype.
So does the doctor diagnose that they have a neuropathy due to ATTR and just ignore the heart, or do they not even know that the neuropathy is due to ATTR? I mean, it seems like if you know that the person has this, then you should test for the cardiac manifestations.
Yeah, no, definitely. I think one of the major things is really establishing a diagnosis. The problem with TTR, whether it's neuropathy or cardiomyopathy or both, is some of the symptoms are very nonspecific, right? So a patient goes to a PCP and says, well, I feel kind of weak, I have some neuropathy. They get tested for the routine things, for example, their thyroid, for diabetes, but a lot of times they don't think about asking them, hey, do you have a family history of this? They don't think of TTR polyneuropathy, just because at the end of the day, it's not very common. And then when they do get diagnosed, I think if they're established to have a hereditary TTR pathogenic variant, then they should be systematically screened for cardiomyopathies. That does not always occur, and it depends, I think, of the knowledge based on their provider.
All right, well, there you go. Knowledge is important. If you have a neuropathy or polyneuropathy due to amyloid, be testing for the cardiac manifestations. Great take-home message, Richard. Thanks for joining us here today live from ACC 2025.